I'm going to introduce our speaker, who we're super excited to have with us today. Amber Moore is presenting today. She is currently a program manager for the West Virginia Department of Health and Human Resources Bureau for Social Services and is a licensed social worker. She manages policies and programs for adult protective services, substitute decision-making, home finding, adoption, adult residential services, unclaimed deceased adult bodies, homeless services, and legal guardianship. Before serving in this role, she worked as an APS adult services policy specialist, adult protective services worker, and a social worker. She has a Bachelor of Science in Psychology from Fairmont State and is currently pursuing her MSW at Concord. In her free time, she enjoys spending time outdoors in wild and wonderful West Virginia. Whether it be sun shining or snowing, the native West Virginia can be found with her family wandering the hills of our beautiful state. That's great. Thanks, Amber. So I'm going to turn the presentation over to her. One last brief thing, she has agreed to make the PowerPoint available, so we will be emailing that out to folks after the presentation today. So welcome, Amber. I'm going to turn it over to you.
Thanks. I feel like every time we discuss the programs and policies, it is such a mouthful. There's so much to adult services, and now added on top of that, the adoption, home finding, and legal guardianship. But it is nice. It's wonderful to be with you all today. Thank you for spending your lunch hour with me as we go through this presentation. Let's see if I can get my presentation up and going. Okay, can you see? Excellent. Let me minimize this. Okay, so we're going to be talking about the tough decisions, the department as substitute decision maker. Learning objectives for today is to discover the goals, mission, and vision of adult services, learn substitute decision-making program eligibility criteria, define key terms, identify the different roles of substitute decision makers, and apply those concepts into your practice. Okay. It is the mission and vision of adult services to provide support and services to adults in order to improve their maximum self-reliance, independence, safety, well-being, community inclusion, and the highest quality of life possible. Our focus today will be on substitute decision maker services, but just a little bit of all of the adult services that we offer. First and foremost, most people think about adult protective services, which we receive and investigate reports of maltreatment of vulnerable adults, and that may result in case management. We'll talk about those a little bit. Maltreatment of vulnerable adults includes financial exploitation and abuse, neglect, and self-neglect. We also do adult family care home finding, which is the recruitment of compassionate individuals and families to provide high quality adult family care. So that is when individuals open up their homes to up to 3 individuals, and they provide kind of lower level care for those vulnerable adults. Adult residential services provide supportive living for adults in adult family care homes and assisted living facilities statewide. So what we do for that is try to match clients with the appropriate level of care. We can also subsidize depending on what their income is. We do provide homeless services for adults and families who are experiencing homelessness. Of course, what we try to do is get stable housing and get them connected with services for appropriate stable housing. The substitute decision maker services, we provide decision-making services for adults who lack mental capacity or are protected persons. We'll get into all of those definitions as we go through the presentation. We also work with unclaimed deceased adult bodies, and what that is providing disposition for those bodies. So working with funeral homes on cremation or burial, or really trying to find family members who can make that disposition instead of the department. Any questions so far on our programs?
Don't look like there are any questions in the chat.
Thank you. So how do you make a referral for adult services? You can call the Department of Health and Human Resources Centralized Intake. We are open 24/7. I did see some CI people on here, so hello to you all. The hotline number is up here. It's 1-800-352-6513. Mandatory reports for adult protective services are sent through them, but you can also do request to receive referrals for our other programs in which I mentioned. Anytime you're making a referral, there's specific information that they're going to ask you. And we're hoping that you'll be able to provide, of course, name, address, the current location, very specific information as to, why you think that person is vulnerable or they lack capacity or meets the definition of a protected person. What type of services are you requesting for that individual? And we also take self-reports as well. Our philosophy, anytime that the department becomes involved with adults, the intervention must be at the least restrictive level possible and appropriate to meet the needs of the individual while assuring the highest degree of autonomy and self-determination as possible. We work with adults, and just because somebody lacks capacity or are considered a protected person, we want to honor their wishes as much as possible in keeping them safe and keeping them, free in their own community, whatever it is for that specific individual. Anytime we get a referral, we're going to begin assessing their circumstances. We're going to look at the individual's strengths, their needs, their environment, who is their caregiver if they have a caregiver, other members of the household, and any previous adult services involvement. So when looking at strengths, just because somebody requires services does not mean that they're not capable in aspects of their lives. So what are your strengths? And thinking about that on a personal level, we all have strengths, we all have needs as well. Does that individual, are they able to manage their own finances? Are they able to meet their own physical needs? Do they have a good caregiver or a good support system? Caregiver doesn't have to be in the home. It could be somebody who drops by to see how an older adult or a vulnerable adult is doing. This is really important for folks to understand. So adult service workers form an opinion on mental capacity. We do not actually assess capacity. That has to be a medical professional or a psychologist. There are many cases when our observations alone will not give us an accurate picture of mental capacity. We're going to look at how has that vulnerable adult in their lives, what is the change? Do they have dementia or, any other cognitive diagnoses? There are times that we will have to contact a primary care or attending physician to have a formal capacity evaluation completed. Goals of substitute decision-maker services. An adult who receives substitute decision-making services from the department is engaged and they are an active participant in their services and decision-making. We work with other professionals to educate clients on the benefits or consequences of compliance or failure to comply with medical treatment and other decisions. We facilitate the development of the adult's maximum self-reliance and independence, including the availability for less restrictive alternatives. In order to make appropriate decisions, we're going to look at their best interests and also in accordance with their personal wishes and values. Considerations will always be given to medical conditions, the prognosis of that individual, their dignity and uniqueness, the possibility and extent of preserving life, preserving, improving, or restoring their functioning, relieving suffering, balancing the burdens to benefits of proposed treatment or intervention, and other concerns or values. It is important to know that we cannot guarantee nor force compliance with the recommended course of treatment and/or medical care. The department cannot force adults to exercise good judgment, take medications as prescribed, and comply with medical procedures or maintain acceptable personal hygiene. So now we're going to get to the meat of this. Any decision-making authority that we have is based on the scope of the appointment. Today, we're going to talk about healthcare surrogate. We're going to talk about different types of guardianship, whether it be a temporary, limited, or full guardianship. So, what is a healthcare surrogate? That is a decision maker who is 18 years of age or older, who is reasonably available, willing to make healthcare decisions on behalf of an incapacitated person, possesses the capacity to make healthcare decisions, and is identified or selected by the attending physician or advanced nurse practitioner. The capacity to make healthcare decisions is based on the evaluation of the person's mental capacity. Like I said before, we do not make that decision. That is up to a medical professional.
Amber, there was a quick question in the chat about that.
Absolutely. Yeah.
They were asking if it's helpful to fax the incapacity statements with the referral form.
Yes, that would be very helpful. As much information that we can have at the time of making a decision, the better off it's going to be. So, what is mental incapacity? It is the inability, because of mental impairment, to appreciate the nature and implications of a healthcare decision, to make an informed choice regarding the alternatives presented, and to communicate that choice in an unambiguous manner. So this definition is pulled from West Virginia State Code, Chapter 16, Article 30, for those of you who really like to get into the law and read those definitions for yourself. It's important when we're talking about capacity, there's different types of capacity. You might be able to make those financial decisions, but not the medical decisions, or vice versa. And there are different powers of attorney and things that can come into play that can assist folks in making those decisions as well. Anytime we're assessing whether or not the department should become the healthcare surrogate, we're going to look at the different eligibility factors. So the client must be at least 18 years of age or older, or an emancipated minor. And in the state of West Virginia, you can be an emancipated minor at the age of 16, go through the court process to do that. They must be a resident of West Virginia or be physically located within the state. As many of you are up in Morgantown, you get a lot of folks from Pennsylvania. As long as they are located within the state, we can be healthcare surrogate. They must lack decision-making capacity as determined by a qualified physician, psychologist, physician's assistant, or advanced practice nurse. They must not have a known advance directive that is duly executed and in effect, or if they do have one, it does not adequately meet the individual's needs. So in their advance directive, they may have said, okay, I want DNR or whatever that is. All the other decisions have to be made as well. They must not have a person who is able, willing, and appropriate to serve a substitute decision maker. And we'll get into there's a ranking according to state code as to who should be chosen as that decision maker. Any questions on eligibility?
No questions in the chat.
Awesome. So in selecting a surrogate, the attending physician or advanced nurse practitioner must make a reasonable inquiry as to the existence and availability of a surrogate from the following persons. So first, the person's spouse, then the adult children, then their parents, adult siblings, adult grandchildren, close friends, and then number 7, any other person or entity, including but not limited to public agencies, guardians, public officials, public and private corporations, and other persons or entities which the department may from time to time designate. So of course, that's where we fit in as number 7. Anytime you're going to have somebody on this list, they need to be chosen first above us. We are last resort always for surrogates and for guardianship. When looking at, does the person know the individual's wishes? What was prior contact with the individual? Has a proposed surrogate demonstrated care and concern? Do they have the availability to conduct visits? And can the proposed surrogate engage in contact with healthcare providers to participate in the decision-making process? And this information, and I hope this link works. Let's see if we can get it to work. Okay. This is the healthcare surrogate form. Many of you have seen this. And this will be completed by the physician or the medical professional who's making the decision that they lack capacity. And I'm not going to read through all this, and I'm trying to go slow so I don't make you dizzy. These are just basic questions about the incapacity. And then the selection of the surrogate. So you'll see that the list of folks who should be chosen are in order.
Amber, there's another quick question in the chat while you're scrolling through. They want to know what if the willing surrogate does not reside within the state? Oftentimes well, hold on, there's two questions. Oftentimes we appointed the client's child who lived outside the state, but it was available by phone or Zoom.
I think that's very appropriate. Anytime you're going to have someone who knows that person's wishes, they need to be the person who is appointed. If they are the most qualified candidate, even if they live out of state, I think that they should be chosen.
And then there's one other question. If an individual would benefit from a healthcare surrogate, would a professional call the hotline asking to make a receive services referral for HCS to start the process?
They can do that. They can also call the local DHHR in order to make that referral. And when I say local, it gets a little interesting. So if you are, it needs to be made at the residence of that individual. So just because I'm at WVU in Morgantown, the referral for me would be made in Nicholas County because that's my residence. So calling the Mon County office is probably not the most beneficial when you should call the resident office. Any other questions?
Nope, no more.
Awesome.
One quick thing, Amber, I noticed that when you lean back, we lose your microphone.
Oh, okay. Let me get
Yeah.
closer.
There you go.
How's that? Okay. Number 8 on this list is very important. The patient must be notified of the determination of incapacity and who the surrogate will be. You know, we are, again, working with adults and they have the right to be informed about their care and who would be making those decisions for them. And many folks can voice that opinion as to who they would want to be making those decisions. And this also is really important why everybody should do advanced directives, because you never know when something may happen to you and you need somebody to make those decisions for you. So do your advanced directives. There's my little soapbox for the day. Anytime that a person has been deemed to lack capacity due to a psychiatric mental illness, this form looks outdated, but it's not. This is a 2022 intellectual or developmental disability or addiction, and the treatment is to be authorized by the surrogate is for mental illness, then there has to be 2 physicians or licensed psychologists to state that they lack capacity. If a family member who was not selected disagrees with the surrogate chosen, inform them that it is their responsibility to notify the attending physician, and they can also go to court to challenge the selection of the surrogate. So then it will be up to the judge as to who should be acting as the healthcare surrogate. Any questions about the surrogate selection checklist?
Nope, no questions in the chat.
Awesome. And if you are working with us, we do need the original copy of the selection checklist. So that will have to be mailed to the local office. We have to have that on file. Healthcare facility may rely upon the decisions of the selected surrogate if the provider believes, after reasonable inquiry, that a guardian or representative under a valid applicable medical power of attorney is unavailable, incapable, or unwilling to serve. And I'm sure many of you have encountered that. We do get appointed when there is a medical power of attorney. However, they are not reachable. That does happen. And sometimes we're able to work that out, notify the medical power of attorney that we have received a healthcare surrogate request and that they need to be in contact with the hospital or other medical facility. Again, there has to be no applicable advance directive. There is no reason to believe that such healthcare decisions are contrary to the incapacitated person's religious beliefs. And so it's really up to the medical professional to understand, is to the extent possible, cultural and religious beliefs that they have. And that's done through, investigation, talking with family members, things like that. And we're going to look at that too when we're making those healthcare decisions. What is their religious beliefs? What are their cultural beliefs? The attending physician or advanced nurse practitioner has not received actual notice of opposition to any healthcare decisions. So if we're making those healthcare decisions, they can be relied upon by the medical professional.
Oops, we
Things
do
get
have
a
a,
little, go ahead.
sorry, we do have a comment in the chat. Do you want me to bring it up
Yes.
now or wait? Okay. So someone said, is there any way we can advocate for DHHS to change the phrase mental retardation to developmentally delayed?
That, I would agree with that. However, this is not a department's form. That actually comes from WVU Center for End of Life. Or who is making that form and making the revisions to that form. But I do have a contact there that I could reach out and give that suggestion, because that definitely needs to be changed. I'm just going to make a little note of that. Okay. Thank you for that. Okay, conflicted decisions. A duly executed advance directive shall serve as the primary source of decision-making on the behalf of an incapacitated adult. If another individual on the surrogate checklist disagrees with a surrogate's decision of withholding or withdrawing life-prolonging intervention, so, excuse me, feeding tubes, mechanical vents, anything, it could be IV fluids, all of those things. The medical professional shall document the objection and notify the challenging party that the decision will be implemented in 72 hours unless a court order is received. So if, we were appointed and there's a family member, first off, who disagrees with the appointment, they can go to court. But if they disagree with the decisions, they also have the right to go to court to have those decisions reversed. Individuals also have the right to challenge that. Oh, and I just talked about that. Okay. Surrogate changes. If a person who ranks higher in priority relative to a selected surrogate becomes available and willing to be the surrogate, the person with higher priority may be substituted for the identified surrogate unless the attending physician determines that the lower ranked person is best qualified to serve as the surrogate. So sometimes we are appointed, and through our investigative process, we are able to locate family members, and they may be out of state, as someone had discussed earlier. And what we do is notify the physician, hey, we found an adult child, they live in Ohio, they're willing to be the healthcare surrogate. So then the physician would do a new form appointing that individual as the healthcare surrogate. Do you have any questions about the ranking of possible surrogates?
There are no comments on that. There are a few comments about the the wording on the form.
I agree.
So, but no, nothing else.
So, what kind of decisions can a healthcare surrogate make? Medical services, treatment required to address healthcare needs, which may be medication consents, physician's office, so who is going to be the primary care physician, clinics that they go to, home health care, ambulatory healthcare, hospital and hospice decisions, palliative care. It could be as simple as a PRN Tylenol. We do make all of those decisions as healthcare surrogate. We will also make decisions about placement in or discharge from a medical treatment setting. So the nursing home facilities or other healthcare setting, someone who's being transferred to a different hospital. We typically, we're not going to know about transfers from hospitals until after that's happened, and that's to another hospital. Now, if someone is being sent to a nursing home facility, skilled nursing setting, then we do need to be made aware and give consent, because then we're going to be doing all the paperwork, all of that. Any healthcare to be provided or withdrawn, authorization, withholding, or withdrawing of life-prolonging interventions, as I mentioned before. Also, we can make decisions about autopsy, organ tissue donation, burial, cremation, or funeral arrangements. Typically, a healthcare surrogate is going to end upon death, but if there is absolutely no one else who can make those decisions, we can make those decisions on behalf of that individual. It's very important for us that when we meet with someone who we're going to serve as a healthcare surrogate, that we find out their wishes and their beliefs immediately. So we're going to do that in usually our initial face-to-face if they're able to tell us those wishes. Any questions about the decisions that a healthcare surrogate can make?
There is a decision there. I mean, no, sorry. There's a question about ranking, actually. Would ranking be decided based on the ability, I guess, to transport an incapacitated adult to another state hospital? Oh, he says you answered his question. Never mind.
Okay.
Never mind. No questions.
Good. I was confused with that. All right. And this may expand upon the state hospital a little bit more, because as a healthcare surrogate, there are certain decisions that we cannot make regarding services that are not related to healthcare or medical needs. Authorization of placement in or discharge from a residential setting, authorization of placement in state psychiatric hospitals, and financial decisions. So sometimes we get in these situations where we may have a client who maybe they were in a situation where they were being maltreated, and the setting wants us to say, okay, can the adult child come and do visitation? That would not be a decision for us to make, because we are only making those healthcare decisions. The residential settings, so looking at the intensive care facilities, the ICF, unless it's for medical reasons, we would not make that decision. We're not making decisions about going into an adult family care or assisted living setting. That adult still has the ability and the right to make the decision about where they're going to reside, unless it's a medical setting. It gets a little tricky. Are there questions about that? Or specific settings, maybe?
No questions in the chat.
Okay. And this financial decisions, excuse me, I'm sorry, my phone's ringing in the background. We will never make financial decisions, whether we're guardian or healthcare surrogate. Before I go into guardian, are there any other questions about healthcare surrogacy and the department as healthcare surrogate?
So there is, somebody just put a question in the chat. If someone is going into a specialized family care home for personal care services, can HCS make that decision? Personal care services can be feeding tubes and other medical care.
If it is medically related, yes.
Any other questions? No? Okay.
Awesome. So I started with healthcare surrogacy because it's the least restrictive of the two decision-making services that we do. And as I mentioned at the beginning of the presentation, we always want to be least restrictive. So anytime that we could be healthcare surrogate as opposed to a guardian, we are absolutely going to take that route. There are times that that's not the case, and we do have to look at guardianship. So what is a guardian? They are a person appointed by the circuit court, and that is the county of residence, the circuit court of the county of residence of the individual. And they are responsible for the personal affairs of an individual found unable to make critical life decisions, such as healthcare, placement, and means of support. The individuals requiring a guardian are referred to as protected persons. So Chapter 44A of West Virginia State Code defines a protected person as an adult who has been found by the court because of mental impairment to be unable to receive and evaluate information effectively, or to respond to people, events, and environments to such an extent that they lack capacity to meet the essential requirements for healthcare, safety, habilitation, or therapeutic needs without the assistance or protection of a guardian. So, what is the eligibility for the department to serve as guardian for an individual? They must be at least 18 years of age. They must be a resident of West Virginia. They appear to meet the definition of a protected person, and they have no known person who is able, willing, and appropriate to serve as substitute decision maker. And you'll see in here, it talks about we can be temporary guardian, limited guardian, and full guardian. And that's up to the court to make that decision. Who can file the petition to the court? The person themselves may file the petition for the department or anybody to become guardian. The person who is responsible for care and custody, the facility who is providing care, the person who is nominated by the alleged protected person, the person who is acting as de facto guardian or conservator, and any interested person. Also the department. So the difference here between guardian and conservator, guardian is making those life choices while a conservator is making financial choices. Some folks will not require a conservator and only need a representative payee. So someone who does not have assets or income over $2,000 a month would only require a representative payee if they receive Social Security benefits. Any questions on who can file the petition, what a guardian is, or what a protected person is?
There is one question in the chat. I'm not sure if they're asking if they can be a guardian, but they're saying, what if there's a family member that is out of the country, but they are constantly in the person's life and can be contacted for a guardian?
That would be up to the judge of the court. There's nothing in the law that prevents that. Ultimately, it's the judge's decision.
Yeah, and that's all we have.
Not going to read all of this, but whenever a guardianship petition is filed, we have to also file a physician or psychologist evaluation. It's not, it's in depth more than the healthcare surrogate checklist in some ways and not in others. But really it talks about why they believe that the person needs a guardian, what are their conditions that require a guardian to be appointed, what types of services that individual needs, including medical services, but also the living arrangement for that individual, whether the appointment should be a full appointment, limited, or just a temporary appointment. And ultimately, again, that's up to the judges to decide if it should be a limited appointment, full. We're also going to ask the opinion of the physician whether or not the person can attend the hearing. We always want them to be at the hearing if possible, but there are circumstances that it may be dangerous to their health to attend. So somebody's at the hospital and leaving the hospital would have ill effects on their health. Any questions on the evaluation?
I'm not sure. This person said, is it okay to advocate for a family member? And I'm not sure what they're referring to. So
They can come off mute if they'd like.
oh, to be a guardian.
Yes, and we're always going to advocate for family members to be guardian over the department. Just like healthcare surrogacy, we are the last resort, and we do want family members or even friends to be appointed above us.
There's one more question. It has been my experience that for physicians or psychologists who are associated with the residential agency, almost always mark full guardian whether a person needs that level of assistance or not, because that is what the agency wants.
Well, I can't speak for physicians, but we're always going to, as far as the department is concerned, we want to be least restrictive as possible. So having those conversations with the judge during the court hearing is very important as far as we're concerned. Okay, and as I've mentioned, there are temporary, limited, and full guardianships based on the scope of the guardianship appointment. by the judge. And so the physician can recommend, whatever, whether it be a full or limited, but it really is up to the judge to make that decision. So decision-making authority may involve the following unless it is specifically excluded through the court order. Healthcare to be provided or withdrawn. So building upon those decisions that a healthcare surrogate can make, services and treatment required to address needs, authorization of placement in a nursing facility or other healthcare setting, where the protected person will live, changes to residential setting, resources to meet educational needs, the protected person's means of support. So looking at, state benefits such as Medicaid, SNAP, possibly TANF, depending on the situation. But also Social Security, we can make those applications with them. VA pension benefits, any type of income. Also relationship decisions. Again, we cannot make financial decisions. To talk about those decisions a little bit more, we can make relationship decisions as far as visitation, and even as intimate as dating. We cannot make decisions about marriage, divorce, termination of parental rights. All of those things have to go back to court. There are certain situations where the court will make those decisions. We can bring that information to the court and allow the judge to make that decision. Any questions on guardianship decisions?
No questions. I don't see any questions in the chat.
To conclude, adult services programs provide support and services to adults in order to improve independence, safety, well-being, and the highest quality of life possible. This is achieved through adult protective services, residential services, homeless and substitute decision-making services. And so I really do want to spend the rest of this time discussing issues that you may have, any questions that you have. We can talk about specific situations to an extent, but I'd love to open it up for you all to discuss things.
So if you have a comment or question, feel free to type it in the chat. You can also just unmute yourself and speak. And I've also, while we're waiting for folks to think of questions, I just put a link to the evaluation survey in the chat. So if you can do that before you go, that would be great. Okay, we have one question. What do we need to do if there is someone who is higher functioning but has intellectual disabilities and their legal guardian restricts many of their rights, such as not allowing them to make their own decisions or not allowing them to leave their house without permission?
Well, that's an interesting situation. If you feel that a guardian is not acting in the best interest of an adult, then it can go back to court through a modification petition. So you can request that somebody else be appointed instead of that individual. Go here to this to show you all some of these forms. So that specific form, it's the modification. Here we go. Petition for termination, revocation, or modification. I would suggest if that individual, first off, do they really even require a guardian? You could look at petitioning to terminate completely if they do not require a guardian. If they're higher functioning, not everybody needs to have a guardian just because they have an intellectual or developmental disability.
Somebody said, thank you for saying that.
Absolutely.
In all caps.
Well, I agree with that statement. So
there's another question. Can you hear me?
I can.
Okay. As a case manager in crisis support and recovery center for substance use disorder clients, can I refer clients to APS for assistance with housing to increase their odds for abstinence?
adult residential services, we're going to be placing in adult family care or assisted living. And so I would imagine that that individual does not require that level of care. I could be wrong. But that is kind of a restrictive setting because they're being placed in either someone else's home or in an assisted living facility. And there is medical requirements specifically for assisted living, but also requirements for adult family care in order to meet the eligibility for that. When we are looking at someone who's experiencing homelessness, and I don't know if that's the case upon discharge for that person, we work with the local continuum of care. So there's 4 COCs across the state. The West Virginia Coalition in Homelessness, they have 44 counties, Kanawha Valley Collective, the Huntington COC, and the Greater Wheeling Coalition. So we would work with them in order to get that person in stable housing. So I don't know if that's kind of the situation that you might be talking about, but the best thing to do there is to contact the coordinated entry system for that county. What county is that person in?
The person who had that question, can you type in what county that person is in? And we've got a couple other questions coming too. Okay, somebody just put a phone number in there for WVCH. Okay, so there's no, we can move on to other questions maybe. And I don't know if Amber, if you're going to provide contact information, if folks want to follow up with specific questions, would that be? Oh, here it is, Berkeley County. He says, I have several resources, but oh gosh, there's a lot of stuff in the chat. Several resources, but more is better, is what the person is saying.
I agree. I think I'm going to stop sharing, and then maybe I could look at faces. I'll put my contact information in the chat box as well, and it is at the end of the PowerPoint.
Perfect. So we've got a bunch of other questions. And we've got time. So can a guardian can sign someone into an assisted living or personal care home, but a surrogate cannot sign that paperwork? I understand they can both sign nursing paperwork. So I guess they're wanting clarification on who can sign what.
Right. The client should be completing their own paperwork, their admission paperwork to assisted living or adult family care, because it's not really considered a medical setting.
Okay. And then there's another question that says, this may be beyond the scope of this conversation, but can a medical power of attorney who lives out of West Virginia plan to have the individual to their home state to be come to their home state to be closer to them and have the individual continue to be covered under West Virginia Medicaid, or would they need to reapply in the new state of residence?
I am not a Medicaid specialist. I'm going to start with that. However, it is my understanding that they would have to apply for Medicaid in the state that they are residing in.
And then somebody asked about CE certificates. We will be sending out CE certificates via email after the seminar if you registered by Zoom. So is there a comprehensive list of family care, group homes, assisted living options available somewhere for the state that we could reference?
I don't think so. If you are wanting to do adult family care, we have currently 3 adult family care home finders across the state, and they manage that program. They know the available beds that are open. So you would need to contact your local office. They could get you the contact information for the adult family care home finder for that area, and they can work with you on determining whether or not there are open beds for that. As far as the assisted living facilities, they are licensed by OFLAC. That's the Office of Health Facility Licensure and Certification. They're a sister agency within the department. So they would have, I don't know that they have a comprehensive list of open beds. We've been trying to work through things like that, but the best thing to do is just to call the local office and see if you can do a request to receive for that individual, and we could work towards placement if it's appropriate.
Yeah, and a couple folks noted in the chat that most of the West Virginia counties have their own resource guides, and that those can be helpful. And there's a couple of folks who posted resources in the chat as well related to that. Okay, so here's another question. At Hospice of the Panhandle, it seems that we are constantly faced with vulnerable adults who lack capacity of being left home alone. What is the actual consequence of this? Is there only consequence from APS if there is evidence that a vulnerable person is harmed because of being left alone?
That's an excellent question. So when we do our investigations, yes, we are going to look at harm. Specifically, that would be a neglect situation. But it varies case by case and person by person. So in gathering that information, we're going to talk with family members and physicians to determine if somebody is receiving hospice services. Are there times when they can be left alone, even for a short amount of time, or are we talking, 8 hours a day that they're by themselves? It is very case by case basis, so it's difficult for me to really answer that question. But if somebody does require 24/7 care, there is a caregiver who is neglecting their duties, we would do an investigation. And if we find that they have been neglectful, we would substantiate the allegations and send that on to the prosecuting attorney for that county, and any other entity that oversees. So if they're receiving, Medicaid funding, it could be the Bureau for Medical Services, Medicaid Fraud Control Unit under the Attorney General's office. It's just very case by case as to who would receive referrals about that.
Let's see. There's just a number of things in the chat about resources. That's great that folks are sharing that. Does anybody else have questions or situations they want to bring up? We do have a few minutes left. And I'm going to post again the link to the evaluation survey in the chat. Anybody else have questions?
We got finished early, it seems. I always like having the time to do conversation.
I do have a question.
Yeah.
Sorry, I just muted you by mistake, Alyssa. You have to unmute yourself.
Thank you. I'm curious, Amber, I know that you said if we have a report, if we have something that needs to be reported, we call the DHHS 24-hour hotline. But I also remember you saying that there was a form that needed to be filled out as well, online when a report is made. Can you clarify what that form is and what that process is, please? I'm new to West Virginia, so I appreciate that. Thank you.
Absolutely. So if you're a mandated reporter, anytime that you make an adult protective services referral, then the form needs to be filled out. So do you work for a facility?
I work, I have 2 jobs actually, yes.
Okay, because we do have a process for centralized intake for facilities, hospitals, different settings, where the form can be sent to them via right fax, and it has all of the information. Why don't you, I'm going to put my email address in here. Why don't you email me and I'll send you back the form?
Okay, that sounds great.
It'll probably be the best way to handle this. Because it's not a form that's available online. Now,
Okay.
there's also the carbon copy form.
Mhm.
And the reason why we have a carbon copy form, is because the first page is sent to the local office. It has reporter information. All of the other pages of that form does not have the reporter information. And those are sent to, the OFLAGs, law enforcement, different agencies who also need to receive that report. So I don't know if I have this in the
Okay.
PowerPoint or not, but
So
you can order those forms as well from the department.
okay, what is the form about? Like, what is the form? I mean, if you're already making a report via the telephone, what is contained in the form that isn't contained in your telephone report?
Nothing. It's just, it's old school paper. That's really what it is, because you're going to tell us everything on the phone, and then that report's going to be sent to the office. But it also allows us to communicate between the other agencies who will receive that report as well.
Gotcha. Okay, yeah, I'll email you then and ask for that. And
Perfect.
it sounds like the form is different based on where you work as well.
No, the
No.
information is the same. We've just started this right facts process. I think
Okay.
Justin Ash is on here. He's our director for that. We started that about a year ago, and really it's just so if it's not an emergent situation, right?
Mhm, mhm.
Then you don't have to wait on hold to contact centralized intake to make that report. It gives you the ability to just send it to us and not be on hold. It cuts call times. There's a lot of benefit to that. So you're not waiting to make that report to centralized intake.
Okay, I love that. Okay, thank you so much. I will send you an email about that.
Awesome.
Appreciate it.
Yeah, you're so welcome.
Mhm.
And I think somebody just posted a link in the chat to some information about her documents for it. So I don't know.
Oh, okay, thank you.
She did. And this document is the one that is the carbon copy one. At the bottom of this, you'll see a phone number, fax number, and address for materials management, so they can send you the carbon copy form.
So there's another question in the chat that's asking if they do a verbal report, do they not have to send a form? But it sounds like you have to do both, right?
The carbon copy still has to be sent.
Okay,
Yep.
okay. Hmm.
So you send the carbon copy form to the local office, and then first you call in a centralized intake, then send the carbon copy. Instead of calling in, if you work at a facility, a hospital, we sent out letters last year with this other form. So that would take the place of the call in a centralized intake. But if you work for one of those places and your facility has not received that letter and the right fax form, send me an email and I will get that sent out to you.
Thank you, Amber. This is so helpful.
Yeah, this is some really great information. Fabulous. Does anybody else have questions or things they want to ask? Well, we have a few minutes left. Somebody noted that it is my understanding that the paper form is the written documentation that the mandated reporter did make the referral.
Yep, good response, Katrina. Any questions on any adult protective service, substitute decision making, adult residential? What's the time?
While we're waiting just to see if folks have some final questions. I just want to thank you, Amber, for this great presentation on very important topics. This is really, really super helpful. I am going to post one